So welcome everybody, and today we will speak about neurofeedback, cover the subject of sleep and pain, and but the theme is also integrative medicine, how to this integrate with different aspects. And we have with us very eminent doctor. They are practicing in the private practice in Hawaii, Dr. Michael Russo. He's neurologist and he has a pretty impressive curriculum. He studied at Princeton University. He has also done a career in the military and has so many fellowship here. This is very impressive. Fellowship of American College of Physicians, American Academy of Neurology, and the list is kind of long. And today he's working in a neuroscience clinic and doing some project of research with Stanford University. And we have also with us Dr. Robert Child. Do I pronounce well your name?
Yes.
Okay. And anesthesiologist, and he practiced here for most of your life, right?
Yes.
And performed 40,000 anesthetic procedure. So you probably be familiar with the problem of pain and sleep also. And I'd like to start with Dr. Russo. First of all, what do you see in your practice in general about sleeping? You know, what are the kind of the type of client that consult you? Just the general aspect, just to start with it.
I see that most people don't realize that sleep can be problematic, that sleep can be disordered, and if they address the problem of their sleep, they'll feel much better during the daytimes. So when I bring up, how well are you sleeping? Well, I'm fine. Well, why do you snore so loudly then? Well, maybe I'm not fine. People don't realize the importance of sleep.
And today is like a component of be healthy. You know, we spoke about nutrition and exercise. This is very popular in the last decade. And now it's coming that we start to be way more aware about sleeping and the quality of life. So what kind of difficulty or pathology or, you know, imbalance you met the most in your practice?
Well, I always ask somebody how they sleep and whether they feel rested when they awaken in the morning. And a huge number of the patients do not feel well rested upon awakening, which is a red flag. If you've slept 8 hours and you don't feel well in the morning, there's something wrong. So then I'll ask if they snore, I'll ask how many times they awaken during the course of the night, whether they take naps during the daytime. All of that impacts their ability to do well cognitively and remain alert and functional during the day.
And one of your main tools of investigation is brain mapping, right? You will investigate this client.
Yes.
Doing on them some
well, we actually, for sleep,
yeah.
We have a 3-channel EEG that you wear like one of these Apple watches on your forehead, and it maps your sleep all night long, and it gives you what's called a hypnogram. A hypnogram of the stages of sleep. So you're supposed to fall into stage 1 sleep for maybe 5 minutes, and then stage 2 sleep, and that's about 40% of the night, and then stage 3 sleep for about 20% of the night, and then REM sleep. So you're supposed to cycle through these stages during the course of the night. And this EEG can give you a stage-by-stage analysis of your sleep.
So how long should you be in REM sleep?
About 20% of the night, 25%
of the night you are...
you should be. Whether you are or not, it's another story.
And, you know, what are the brain waves associated with this different level of sleeping, alpha, beta, theta, delta? You know, when you're in the deep sleep, you're probably in the theta mode.
When you're in deep sleep, you're in delta. That's
delta
right.
mode, yeah.
But when you're in REM sleep, there's something called a sawtooth pattern. It's more like a theta or an alpha sleep. And it's a very light stage of sleep. It's the closest stage to being awake. In fact, portions of your brain are awake, and portions remain asleep. The prefrontal cortices, the parietal regions remain asleep during REM sleep, but the rest of the brain is very close to being awake.
So we were speaking previously with Dr. Child about the pain, and there was a component, inflammation, that was very important in this multi-dimensional approach of pain. And what can you, before we go to Dr. Chad, what is, that can be seen? How can you relate this with the sleep and then when they don't sleep properly and the level of inflammation? What are the state of research on that?
Well, there's something called cortical arousals, which is you're not fully awake, but your brain is waking up. So the 3-channel EEG can look to see how many times the brain approaches being fully awake, but doesn't quite achieve awake, and how many times it does become awake. Pain can awaken the brain, even if it's momentarily. So a 1-second awakening, a 3-second awakening, they add up over the course of the night, and they take away from your sleep.
Okay. So how will you relate this with in the tabloid of pain of the
Well, this is very valuable information, and it's an unusual opportunity that someone in my profession who spends the focus of my career on keeping people asleep gets a chance to talk with someone whose sole focus of his goal is to optimize the brain so that it functions best when it's awake. So we're looking at it from opposite angles, but we're actually meeting each other in the middle. It's like we're looking at each other in the mirror. And I see exactly what he's saying when I go in to see my patients post-operatively, maybe even the next day after surgery, and I'll talk with a nurse or I'll talk with a family member, and I'll say, were you able to sleep last night? Or, was he able to sleep? If the patient was able to sleep right after surgery, that means I did a good job. I did a good anesthetic to numb the part of the body that was sore, and I can actually tell frequently by just looking at the expression on the patient's face. Micro facial, if there's a little bit of furrowing of the brow or his eyes are drooping, means he probably didn't get the proper balanced cycle of sleep stages, and which is something I don't understand to the depth that you do, but I understand the quality of my ability to control the patient's pain, not only during surgery, but after surgery seems to affect how quickly they recover. If the patient has slept well, they're more engaged in their environment, they're more energetic, they take responsibility for their own recovery more. They'll get out of bed, they'll make efforts to do their exercises, and it accelerates the return of a natural healed state. So even though I focus my expertise on putting the patient to sleep and putting the nerves to sleep, the recovery of normal awake balanced function is the key to getting the person through that, which is the other part here, which Dr. Russo has been able to explain. Appreciate that.
So pain is one of the components that can be interfering with sleeping. You said snoring too. So
yes.
So how does it work?
More people snore, I think, than are in pain when they sleep. Certainly both can awaken an individual.
Yeah.
So if you're awakening choking or gasping, and your spouse says you're snoring so loudly she has to sleep in a different room, you got a problem. And the problem is probably you have an obstructive apnea, and that's causing you to not breathe while you sleep. And your oxygen saturations drop. Normally they're 98, 97. Well, they could drop into the 70s. And if they drop that low, your brain is being deprived of oxygen while you're sleeping. And then you're not going to recuperate, because sleep is for recuperation of the brain.
So what is the percentage of population today? Because it seemed way more popular than a few years ago, this apnea problem.
With the apnea, it's estimated about 20–25% of the population.
That's incredible.
So a huge number are undiagnosed. And they don't even know, many people, that they have a problem. Because unless their spouse leaves or rolls them over all night long. They wake up in the morning, maybe not feeling great, but they shake it off and they go to work and they perform at maybe 60 or 70% of their maximal or optimal capacity. And for many people, performing at 60 or 70% is good enough. For many people, it's not. So they should be performing at much higher level.
Yeah, because they compare to themselves, their own functioning.
Right.
So what are the approach then? How to correct that? How you...
Well,
there is device now.
It's very easy to diagnose. No longer do you necessarily have to go into a laboratory and spend overnight in a strange room.
No?
You could take a tape recorder home with you, and the tape recorder will monitor your sleep all night long. You download the data the next day after only one night, and you can come up with a real certainty as to how badly the individual is breathing while they're sleeping and how many times they're awake.
So what is the correlation with the EEG and the sleep pattern?
The EEG can show a high sleep efficiency, say 78, 80%, or even higher in the mid-80s. Yet the individual could have very severe apnea because they stop breathing for, say, 90 seconds or 120 seconds. And we couldn't hold our breath here for 90 seconds, but when you're asleep, you hold your breath, and then you wake up, and then you take a breath, and you go back to sleep.
So how does this translate on the EEG?
The EEG shows an awakening. The EEG will show that an individual awakens.
So what's the difference with the pain awakening and an apnea awakening?
They're both awakenings. It's just different reasons for the individual to be awakened.
Yeah, but I was wondering, because you said you can detect, you don't have to go in lab anymore, so how you detect that is a lack of or an apnea?
Well, we can detect it because there are three components to the tape recorder.
Okay.
The first component is a belt that stretches around the chest, and it looks at respiratory effort, expansion, contraction of the chest, and it gives you a curve as you breathe. So
you have a diaphragmatic measurement, you know.
It's a quantitative measurement of moving of the chest. The second
diaphragmatic,
The second is a pulse oximeter. It sits on your finger, and it monitors your pulse all night, and it monitors the amount of oxygen in your blood. So you're supposed to be in the 90s. If your oxygen level drops into the 70s, this monitors it and tells you for how long. And then there's a cannula that sits under your nose. It's a little tube, like from a fish tank. And it sits there and measures airflow. So say your chest is pumping in and out, but there's no airflow.
So
and then your oxygen drops. There's an algorithm that says your chest is trying to move, you're not moving any air, you're not breathing. And if that happens for a long enough period of time, you wake up, take a breath, and then go back to sleep. So that is a sophisticated tape recorder. So it has 3 channels that monitor.
And this is recent, I think, this recording. Is it recent?
Yes, maybe the last 10 years. So it's now required by the insurance companies. You can't just send somebody for a sleep study in a laboratory if you're looking for apnea, because they charge like $1,200 a night. This test reimburses only like $200 a night. So the insurance companies could get 5 of these tests for the equivalent to 1 in-laboratory test. So it's driven by the insurance companies, really, to save money for them.
Good.
Yeah, so we can diagnose it overnight. I give it to you today, tomorrow, I can tell if you have sleep apnea. And the insurance company saves money.
This is significant for the practice of anesthesia and the safety of a patient that is going to have an anesthetic, because the risk factors of complications of breathing under anesthesia go up significantly in patients that do have sleep apnea. And it's very frequent that I have patients coming in for elective surgery that give a history that sounds like they've got sleep apnea, but they haven't had the test yet because it's more difficult to get the approvals to have these tests done. But what we do know is that the effect of any anesthetic, it's like the effect of a beer is an anesthetic. It relaxes you. And any anesthetic will relax all of your muscles, including the muscles of your neck and pharynx that are normally a little bit under tension, that are holding the opening of the airway open so the air can go in and out. Now, when you go to sleep, you normally become relaxed, your muscles relax, and the muscles that are holding your airway open relax a little bit. But in people that have a tendency to sleep apnea, it's either they become more relaxed, they're more sensitive to the relaxation effect of sleep or drugs, so that the airway opening actually folds shut. Or in some people it might be due to the shape of their neck being very thick, or they're excessively obese or something of that sort. But the end result is that during the anesthetic, there may be circumstances in which it becomes very difficult to get oxygen or air into the patient. So the oxygen level drops, which, if it drops low enough, can cause a heart attack or a stroke or even death. Now, the circumstance that is a more serious condition of sleep apnea is when, as Dr. Russo referred to, the oxygen level drops significantly. And when the oxygen level drops significantly, it causes emergency alarms to go off in the brain, which is one of the reasons that hopefully you're going to wake up and take a deep breath. But the other effects of these emergency alarms release hormones, substances in the blood that actually try to save your life. They cause the heart to beat more forcefully, to push more blood because there's not enough oxygen in the blood now. They cause the blood vessels in your body to constrict, to try and force more blood through. And if that is going on every night for days and years, it exhausts and causes permanent damage to the blood vessels in the lungs and the heart. And you can actually be in a state of being virtually on the edge of dying as you're walking through life during the day, just because your heart's worn out, the blood vessels in your lung are worn out. In addition, your brain's worn out from not sleeping, so the operating command system is not sending good messages on how to compensate for the actual physical changes, physiological changes in your body, and the mental changes from lack of sleep. So it's a very serious, significant problem, and contributes significantly to risks related to surgery and anesthetics.
Yeah, you paint a picture that is some extreme, a bit. So, but what about the prevention? So, what you will can you approach this more in a preventive way? This problem of sleeping, because you know, you said 25% of population may have a problem. So, when or what are the indications to have the test done? You know, and what you do. Is there any way to prevent this without going to an intervention?
Well, prevention is often if you're fit, if you're not obese. Obesity is one of the major risk factors. Okay. So if you want to prevent sleep apnea, first thing, don't get fat. But even thin individuals could have sleep apnea.
What is the ratio? The ratio, let's say
A large number. I don't know the exact figure.
But it's like
But
20% or something like this? Or?
If you're above a body mass of BMI of 30, you're much more likely to have the obstructive sleep apnea. Maybe 50% of the individuals who have a high body mass index will have the obstructive sleep apnea versus a much lower percentage if your body mass index is like 25. So to prevent, you stay thin and you stay healthy. But if you want to treat, you have to determine whether you're going to be on treatment for the rest of your life or whether you're going to seek a cure. And if you seek a cure, you may not need to be treated for the rest of your life. So in
example, you lose of weight and then you...
If you have sleep apnea due to obesity, losing weight is the #1 thing you can do. But as Robert pointed out, the shape of the throat and the mouth, the muscles relax, your tongue falls into the back of your throat, it closes your airway while you sleep. Part of that is the size of your airway. If you have a tiny little airway, it's going to collapse more easily than if you have a larger airway, posterior oropharynx. So the therapies that are now being used to cure individuals include changing the shape of the back of the mouth by putting in an expander. It's like wearing braces for a kid. It will change the shape of their teeth and their mouth. Well, this is a device that exerts outward pressure on your upper and lower posterior teeth to expand your oropharynx, and you wear it every night for a year. And then you could be cured rather than have to be on a treatment for the rest of your life.
Interesting.
So it's better to be cured than it is to be
Many
treated.
does this choice? So what is the...
It's relatively new. Probably only the last 5 or 6 years has it reached mainstream dentistry. And these are made by dentists. So there's a very close association between MDs in medicine diagnosing the obstructive apnea and the dentists who are better able to treat it than the MDs are. So the dentists make these devices, or they'll measure the teeth, they'll send them to a laboratory, they'll come back with a device, the individual wears it every night, and then over a period of a year, maybe longer, their mouth changes, the shape changes, and they can be cured of the apnea. Now, it's not mainstream because it's expensive. These things are $3,000 to $4,000, and they're not covered by insurance. So people have to pay out of their pockets for these, and not everybody has $3,000 or $4,000 that they want to use to change the shape of their mouth.
Yeah, but the device for apnea is not...
It's covered by insurance.
It's covered.
So the treatment using the CPAP machine, which is the continuous positive airway pressure machine, is covered by insurance. So people usually choose the treatment because it's more affordable than the cure, which is more expensive.
And what are the... When can you ask a test covered by the insurance? What are the indications or the main sign, symptoms?
If anybody has excessive sleepiness, or if they snore, or if they have frequent awakenings.
Just snoring could justify?
Snoring can get you a test.
Okay, good.
It's not hard to get the test because the insurance companies realize that untreated sleep apnea is going to cost them a lot of money in the future.
A lot of problems after, yeah.
So they're more than willing to let us diagnose and treat this at an early stage before the patient is in the ICU with a stroke and a heart attack for a month, which costs them a ton of money. So they...
So you spoke about weight. What about meditation? Help, or is there any research or studies done with this to improve the quality of sleep? I saw this. There is some study done that people meditate, sleep better, among all the other benefits.
Well, if one meditates prior to going to sleep, you're more likely to be able to initiate sleep with a shorter latency. The latency is from the time you close your eyes to the time you actually fall asleep. Many people's minds activate. They become more awake as the evening progresses. So if an individual is able to meditate, calm their mind down, place themselves into an alpha state, move the alpha state to a theta state, they're closer to sleep, and they'll be able to fall asleep and remain asleep better than if they're activated and excited. So yes, and the meditation can be very helpful.
Meditation, lose weight. Anything else?
Make sure you have good dentition. Make sure your teeth are in good shape.
Mm-hmm.
So visit your dentist.
What about probably exercise too, if you are you exercise?
Well, exercise, I believe, is very important towards keeping your body fit, because your body's purpose is to protect your brain. And if your body is in poor shape, your brain is not going to do well. So if you exercise, you're more likely to be able to keep your brain functioning well. So that's very important. Not everybody believes in that, though.
Good. So do you have other questions you would like to ask regarding that?
Well, I'd like to comment. My own observation is, because of what we discussed of the significant potential seriousness of sleep apnea, I always question my patients in detail if they have a history of this. And it's very remarkable to me that the patients that are using the CPAP describe it as dramatic. They said, I'm like a whole different person. It's a whole different world. They've never experienced what it's like to actually be awake and engaged all day long, because up until that time they were operating on half the cylinders in their brain. So this management of sleep apnea, from my observation and my discussions with my patients, is very beneficial. From the point of view of pain and pain management, I know my experience in anesthesia that I can get my patient to go to sleep with much smaller doses of potent anesthetic drugs, and I can have them wake up faster, and I can have them recover and feel better because they don't have the side effects. If I get them to do a little meditation and relaxation exercise before we even go into the operating room, before I give them any drugs, that the process of going to sleep, even if you're having anesthesia, optimally involves some guided imagery, some meditative type of practice, relaxation. This has been studied and proven statistically in large groups of patients, in large institutions, to show that there are actually cost savings to the hospitals. So the hospitals love this, that the patient would do some guided imagery or meditation before going into surgery, because the hospital, the recovery is faster, the patient is discharged faster, the hospital spends less money. So, I mean, this is a case where economics has directed the flow of our activity to a more productive area, not out of greed specifically, but out of efficiency. So yes, I think the proper preparation of the mental state is going to enhance the sleep experience. And from the point of view of pain, my question to you, Dr. Russo, would be, I know if I have pain, I'm not going to sleep as well. So we want to manage the pain problems, arthritis and other things. But at the same time, if my patient has a better night's sleep, of a more balanced rhythmic sleep cycle, will they experience less perception of pain? Will proper sleep improve their experience or feeling of what their pain is like affecting their life?
Yes, good sleep will change the pain threshold so that they don't feel pain as acutely. So poor sleep, if a feather lands on their hand, ouch. With good sleep, the feather they may not even notice. Hitting their hand with a hammer, they may not feel the pain as severely as if they had no sleep. So poor sleep will increase their perception of pain.
I think this is the best word to finish this interview. Thank you so much, Dr. Russo and Dr. Chad.
Thank you for inviting us. That's wonderful.
Yeah.
Very enjoyable.
Visit quantumuniversity.com for more information.